I'm Dr. Miles Sparrow from the Alfred Hospital in Melbourne, Australia. Joining me are Dr. Asher Kornbluth from Mount Sinai, New York, and Dr. David Ong from the National University Hospital in Singapore.
So David and Miles and I, our group looked at current and emerging therapies, biologics, and IBD. And the study that I looked at that I think is worth sharing because it's something I'm going to take home tomorrow is the look at how we should treat patients with Crohn's disease. Should we treat them the way we traditionally do, looking at their clinical symptoms and how we need to dose escalate their prednisone before we embark on biologics, combination therapy, versus a predetermined strategy using more objective measures like fecal calprotectin and CRP. So the strategy was to dose escalate starting with the usual adalimumab induction, 160, 80, 40 that we all do, then 40 Q2. If the patient got worse in the tight control group based on fecal calpro and CRP, then they would go up to 40 milligrams weekly and then add azathioprine to that regimen. The other group, again, just did it based on subjective symptoms and whether they needed more prednisone. Not surprisingly, and this is published last year, but here they honed down on what were the objective measures. It was basically the best indicators of who needed to dose escalate was the combination of CRP and Calpro. So the tight control group really did significantly better, 46% hitting the endpoint of an improved endoscopic Crohn's score with no deep ulcers compared to 30% of doctors who were treating patients based purely on subjective symptoms. And so, David, what was it that you found most interesting and important to take home next week?
Thank you, Asher. I took home something on novel therapies, and I was especially excited about new oral anti-TNF. As you know, anti-TNFs up till now have been injectables. So with this oral anti-TNF, it's at the moment called OPRX-106, and it's an Israeli product, and they carried out a phase 2A randomized controlled trial. And with this oral anti-TNF, it's a plant-based product whereby the tobacco plant produces a recombinant cell-based protein, which is then cultivated in bioprocessor systems. And with this oral anti-TNF, it doesn't get absorbed systemically, and it was actually carried out, the trial was carried out on patients with mild to moderate ulcerative colitis, and it was shown to be especially effective in this group of patients. And they managed to show endoscopic healing as well as improvements in the Gabos histological score. So I think for me, an oral anti-TNF without the systemic side effects of the traditional anti-TNFs, I think for me that's very exciting, and that's something I'm taking home from this conference.
Thanks, David. What I'll take home from the podium to my practice from this meeting is some further reassurance about the longer-term safety and efficacy of one-way switching to biosimilars. There were two randomized controlled trials that were presented today. The first was the open-label extension of the NorSwitch study. So NorSwitch, which many of us are familiar with, was a one-way switch study, which we'd seen the data out to 1 year last year. And this was a non-inferiority study, which did show that the biosimilar was non-inferior to the originator infliximab, but the Crohn's disease confidence intervals were a little close. In what was the data presented today, which was a further 6 months of therapy, all patients were receiving the biosimilar. So one group continued CTP13 and another was switched from originator infliximab to CTP13. And after a further 6 months of therapy, there was no changes in safety, efficacy or immunogenicity between the groups, which I found reassuring. Similarly, in a joint Korean and European randomized control trial, which we'd seen data to at this meeting last year out to week 30, we saw an extension out to week 54, and this was a double-blinded study in which there were 4 groups, and 2 of the groups received crossover either way from originator to biosimilar or vice versa. And again, with a further 6 months of therapy, there were no changes in safety, efficacy or immunogenicity. I found this reassuring, and I think my take-home message is that with one-way switching, there is, for non-medical reasons, there is justification if there are health economic incentives to do so. Thank you for your attention. We do hope you found this helpful.